Hello everybody, greetings and welcome. It's Peter Cass here. I've had quite a lot of requests to do an ECG workshop online, and one of the issues always with ECG workshop is how complex or not they are. So one of the issues that we have at the moment is how to get you the most amount of information possible in the least amount of time. Now I have I suppose the onerous task, although very important task, of looking at many ECGs during a shift. And so developed a system where in 20 or 30 seconds I can pretty much analyse an ECG that will give me about 95% yield. And what I really am looking for is ischemia and arrhythmia, and a lot of the details of that I might overlook and go into in a lot more detail later. So I thought what we'd do is quickly have a look at some of the basics of ECG, and I'll just bring it up in front of me so I can see it. And so we really only care about two things. We care about ischemia and we care about arrhythmia. So I've got 20 to 30 seconds to look at an ECG. And the value of the ECG is quite important because the rates of mortality and morbidity in somebody with a normal ECG is about 18–19% that are having an ischemic episode or some sort of a cardiac episode. But when the ECG is diagnostic, the mortality and morbidity jumps significantly. Now we need to remember that about 25% or anywhere up to half of the patients that are having an AMI will have a normal initial ECG. So a review of ECGs becomes very, very important. Now I'm not going to tell you how to suck eggs. The QRS complex is the QRS complex, and you guys know it. So the P wave is for atrial depolarization. The QRS is ventricular depolarization, and the T wave represents repolarization. What's important to think about is the ECG in terms of where the depolarization occurs in the heart. And we know that the first amount of depolarization occurs in the septum. And this is a small amount of depolarization that occurs from the left to the right. And then we have a major amount of depolarization that occurs in the ventricles in the opposite direction. And so what happens is when we look at our leads around the heart, we get our sinoatrial node giving off the impulses in through the atrioventricular node into the bundle of His, and we then get the septal depolarization. So that goes from the left to the right. So the leads V1 and V2 will have a very small positive upward stroke. So that's an R wave. They'll have a very small R wave coming in. And in fact, because that's the normal depolarization of the heart, it is abnormal to have Q waves in V1 and V2. If we look at the leads on the opposite side when we have this depolarization in the septum, that's leads say V5 and V6 or 1 and AVL. Because the septum is depolarizing from the left to the right, that is away from the left-sided leads, there will be a very small downward deflection. So it's normal to have a very small Q wave in those leads. But remember, it's abnormal to have a Q wave in V1 and V2. When the ventricles then depolarize, they depolarize with a lot of sort of energy from the right to the left. And so what's going to happen in your right-sided leads is because that energy or that electrical current is going away from the leads, it's going to be a major negative deflection, as you can see. And on the opposite side, V5, V6, it's going to be a positive deflection. That's about all you need to know about depolarization. The other thing you do need to know about is when we're looking at leads in terms of ischemia, we have to bundle them together so that what we're looking at is leads that make some sense. So we look at the anterior leads, so 1, 2, 3 and 4, the lateral leads which have V5, V6, but they're also 1 and AVL, and then the inferior leads 2, 3 and AVF. And rather than trying to look at 12 leads, it's far easier for us to kind of just look at a set of 3 or 4 leads at once, so chunk it down. So I'll look at the anterior leads, lateral leads, and then the inferior leads, and that'll allow me to diagnose ischemia a lot more readily. So my approach is quite simple. And as somebody said, you know, fascicular blocks and left axis deviation never really killed anybody. But knowing the arrhythmia and the ischemia is very, very important. Now, it's not quite always true, but certainly in the initial instances, what we want to do is we want to diagnose these types of basic rhythm disturbances and ischemic disturbances. So I look at the rate And what do I do for the rate? Is it fast? Is it slow? Is it okay? And I'll usually read the rate off the ECG because it's far more accurate than I'll ever be. But depending on which method you use, and you can use a method of one large square, and you can go from 300, 150, 100, 75, 60, so counting down from every large square, or you can count the number of squares and divide them. Whichever method you use, you kind of know that the rate is either fast, slow, or okay, and I think that's really important. I then will look at the rhythm and see whether it's a sinus rhythm or not. So one of the things that I'll do is I'll look for inverted P waves in AVR and upright P waves in lead 2, and I'll know it's a sinus rhythm. I'll look and see, is it supraventricular, is it junctional, is it ventricular, if it doesn't have those P waves. The other benefit of knowing that the P waves are doing that in these leads is that it allows us to work out whether the leads are in the right place. So inverted P waves in lead AVR and upright P waves in 2 means the leads are in the right place. You found some P waves and they're related to the QRS. That's going to be a sinus rhythm. And that's the thing, to then look at the P waves and make sure that they are related to the QRS. I then look at the QRS and say, is it narrow or is it wide? Wide is greater than 3 small squares. So is it narrow, is it wide, and what's the morphology of the QRS? In other words, is there a delta wave at the beginning of the QRS to indicate a Wolff-Parkinson-White? And then the last thing I do is I look at the ST segments and see if there's depression or elevation. And I look at it in the anterior, lateral and inferior leads. And usually that gets me out of trouble in quite a significant number of patients. So if we look at this first ECG, we know that this is sinus rhythm. If we look at lead 2, we've got upright P waves in lead 2 and inverted P waves in AVR. We then look at the P and the QRS, and there's a P first, followed by a QRS in every instance. And then we look at the QRS morphology and whether it's wide, and then we look at the ischemic segments. So what we need to do in terms of ischemia is differentiate between acute myocardial infarction and also ischemia. So whether there's ST elevation or ST depression. And it's important to briefly talk about ST elevation. And there's a varying morphology in ST elevation that you can see here. And the causes of ST elevation are really the ones we need to worry about: acute MI. Second is benign early repolarization, because you need to be able to tell these two apart. Pericarditis, left ventricular aneurysm, vasospasm, or a bundle branch block can cause it. So let's have a quick look at an ECG, or have a look at the waveforms of an ECG, and we can have a look and see this particular ECG here has got what we call, if we look at it, let's assess it. So the rate, 300, 150, about 100. The rhythm, there's a P wave, there's inverted P waves in AVR, there's upright P waves in 2, so it's sinus rhythm. And then is there a P wave followed by a QRS? Yes, there is. What's the QRS morphology? Well, it's hard to tell in V1, V2, V3 because they're having a tombstone anterior infarct. So you've got ST elevation there. And what also makes it, you're not going to miss this ST elevation because it's so big, but what also makes it more likely to be ischemia is the fact that you've got reciprocal inferior changes. So let's look at another ECG here, and if we look at the rate's going to be, 300, 150, maybe 160, 170 there. Are there P waves? Yes, there are. And I think they're inverted in AVR and upright in 2, so it's sinus rhythm. Let's look at the QRS morphology. The QRS is not very wide. It's less than 3 small boxes. There's no slurring upstroke. And let's look at ST changes for ischemia. So if you look at it in the anterior leads, V1, V2, V3, then there's nothing there. In the lateral leads, V5 and V6, there's no ST elevation. And the other lateral leads, 1 and AVL, hang on a minute, there's some significant ST elevation here. So what we have here is a lateral ST elevation. Now let's have a look at the inferior leads 2, 3 and AVF. So there's ST depression there. So what we've got is a lateral infarct, potentially with some reciprocal changes inferiorly. So it's very important to pick those up. Let's have a look at another ECG now. This is somebody that's come in with 3 days of chest pain. And if we look at their rate, so the rate is around 150, 100, maybe 95 or so, according to each box. So each big box, you count down 300, 150, 100, 75, 60. So we've got about 95. If we look at the P waves, they're inverted in AVR and they're upright in 2, so it's sinus rhythm. P waves are followed by a QRS. If we now look at the QRS complexes, they're not wide, they're less than 3 small boxes, they're normal morphology. And if we now look at the ST segments, what we've got there is ST elevation in V1, V2, and V3, and V4, and a little bit in V5. So this is a man with 3 days of chest pain that's presented with this ECG. And so one of our differentials here is ST elevation MI. In fact, this patient had a left ventricular aneurysm. So let's go through and have a look at early repolarization. So if we look at this waveform here where you've got ST elevation and we look at the waveform and there's a concave, so sort of a hanging down waveform between the J point and the peak of the T wave. I think what's important to work out here is that this is what I call a happy face. So a happy face means that you have a concave shape and it's potentially a benign early repolarization. If we look at the shapes then where there's convexity, what we've got, if we draw a line through the J point and the peak, we've got what we call a sad face. And this is potentially an acute MI. It's not that clear cut, but happy and sad faces can help us. So if we look at early repolarization characteristics, ST elevation must be less than 2 millimeters. There must be a concavity, which we showed, and there's this notching of the waveform that we can see here. Sometimes we can call this an Osborn wave. And Osborn waves occurs in one other situation, which is hypothermia. We can call this, there's a notching there, and that's more clearly defined in terms of early repolarization. We can then look at other things which might help us decide that this is early repolarization. They include concordant T waves of large amplitude, diffuse ST elevation. In other words, it doesn't have a territorial distribution, although this particular one does, and it has stability. But if you at least have those first 3 things, so the ST elevation is no more than 2 millimeters, and there is a concave shape, and there's an initial notching, then it's pretty good that this is going to be early repolarization. Let's have a look at another set of ECGs at the moment and see if we can get a diagnosis on these. So what's this particular ECG? What we're seeing here is we've got a rate of how much? I'll get you to calculate that. 300, 150, 100, maybe about 110, 120. We have inverted P waves in AVR, upright P waves in 3, so it's sinus rhythm. QRS complexes not greater than 3 little squares. And the ST segments, if we look at them in different areas, they're a little bit different. So we've got ST depression basically in V5 and V6. In another tute, we'll talk about left ventricular hypertrophy, in other words, having electrical changes that are indicative of hypertrophy. But I will tell you that this has got some changes that are indicative of hypertrophy. And if we look at left ventricular hypertrophy, it tends to occur in the lateral leads. There's a tall R wave, which we saw here. There's a downsloping ST segment, and there's an asymmetrical T wave. And usually what happens is the T wave has this appearance of a tick. And if you see that downsloping tick, it's more likely to be left ventricular hypertrophy. And then the ECG has to have some high voltage criteria. So this isn't quite left ventricular hypertrophy, and it may be ischemic. Next, we need to think about, when we're looking at the rate, if it's a bradycardia or a tachycardia, we need to think about the types of blocks there are in bradycardia. So anything from the Wanky back to the Mobitz 2 blocks to complete heart block. And in the tachyarrhythmias, we need to think of them as narrow complex, wide complex, regular, or irregular. So we'll talk about that in the next tute.